I'm Wallace Jackmon. I'm a psychologist for Avera. I've been with Avera for going on 17 years. I've been in the field 25 years. Started off as a social worker in child protection. I worked at old Charter Hospital. Probably none of you are old enough to remember Charter Hospital, being here at behavioral health across from Sam's Club, right off of Louise Avenue. Worked there for 4 or 5 years. And then I worked at the mental health center here in Sioux Falls for 4 years. I also teach in the MSW program. Actually, it's right upstairs, and I teach in this classroom, and taught at University of Nebraska, Omaha for 3 years. Asked me to talk about basic psychotherapy. I'd probably start off with just saying, I know some of you may be scratching your head, like, why the heck do we need to know about psychotherapy? I'm going to go into surgery, or whatever specialty you might be going into. I also teach the psych residents, too, over at Avera. And what I will say is, I don't care where you practice, whether it's rural practice or a metropolitan practice, you're going to have people that work for you in your clinic, your nurses, maybe people in your own family, and most especially your patients. Many of them are going to be involved in some type of therapy. They're going to have problems. They're going to have depression. They're going to be an FMLA. You're going to have those issues, and the more aware you are of what some of these psychotherapies might mean, the better able you're going to be able to make referrals and help those folks you're working with. And so by definition, we know it's a therapeutic interaction or treatment between hopefully a trained professional and a client. I'll just start off by saying, as you all know and are aware, not all professors, not all waiters, not all doctors, and not all psychotherapists or social workers are the same. There's varying degrees of successful professional folks. And so the same is going to hold true for psychotherapists or master's level social workers. I encourage you all to get abreast as to who are going to be the best people in your community to make those referrals to. That's what's going to build your practice and build you up as a professional. Who performs therapy? Obviously psychologists, psychiatrists. Some psychiatrists, as I know, in Dr. Soundy, and it was Dr. Delmonte came on board. I think they did their residencies at the Mayo Clinic. They did some of their own therapy. And so there are some psychiatrists that are trained to do therapy. Social workers, MSWs are the highest population of clinicians in the United States. About 60% of their psychotherapists are social workers. Clergy, psychiatric nurses, physician assistants, counselors, they're all going to differ in their approaches to their practice and process. This is something I found of interest and I want people to know is in 1980, there were close to 250 different types of psychotherapy or theoretical perspectives. As of last count, 1996, McClellan said 450. The last count I had is about over 600. There's over 600 different types of theory. What does that mean to you? And when I speak to my students, I always ask the same thing when they see a statistic like that. Well, what the heck does that mean to me? Why do I need to know that? Well, the important thing of knowing that is if you know there's over 600 theories, that means that there's different types of work that you can do with different types of clients. And one theory is not going to be in and of and by itself the best theoretical perspective you can use for all clients. And so what I found in just 20-some years of working is there's always a new flavor of the day or a new flavor of the month, I'd call it. And so right now, the flavor of the month is DBT. You're going to hear dialectical behavioral therapy until, the cows come home. There's always going to be some new therapies on the road. And it doesn't mean that therapy is going to be the therapy that's going to work for everybody. It just doesn't. That'd be the same as saying, well, depression, we're just going to prescribe Prozac for everybody. That's not going to work. It's not going to work for everybody. And so there's different theories, and so just keep that in mind as you see these clinicians out in the field saying I do DBT for everybody. No, it just doesn't work for everybody. What are some of the goals of psychotherapy? Obviously, we want to change some behaviors, some distorted or inaccurate thoughts and perceptions, inner conflicts. Primary one is usually problems in interpersonal relationships. 2 variables of note with regards to goals is we want to establish a genuine and special relationship. I would even say that's for all of you, no matter what specialty you go in. And I'll just say if you don't have a good relationship with your patients, you're likely not going to have them come back. They're going to find another provider. And that holds especially true for psychotherapy. There's some research, I may have it in a later slide, called the Lambert's Common Factors Model that refers to outcomes of psychotherapy. And it says over close to 30% of outcome of good psychotherapy is the relationship that's established between the client and the psychotherapist. I would say you could correlate that to you all's practice as well. Is you got a 30% chance of doing well with that client and them coming back to see you again, and then you can bill out again if you develop a relationship with them. If you don't develop a relationship, they're likely not going to come back. And then, the best advertising is word of mouth advertising. Then go back, hey, Dr. Schmo, he's a jerk. I'm never going back to see him in his practice again. So you want to establish that relationship. Effort for therapists to bring about positive change. You obviously want something positive to come from that relationship. What's some of the usefulness of psychotherapy? Anxiety disorders. We're going to say anxiety and mood disorders are going to be the most common disorders for folks that are coming in for treatment for some type of problem. Actually, in the DSM-5, OCD is no longer listed under anxiety disorders. It has its own chapter. Mood disorders are cyclothymic disorder, major depression, dysthymic disorder, bipolar disorder. Addictions, alcohol, drug dependence, compulsive gambling. In fact, I'd gone to a workshop last year here in town at the NASW, State NASW conference, and I don't know if you all have heard this term before, and you may deal with it in some of you all's practice, is teenage erectile dysfunction. Have you ever heard that one before? It's true. Teenage erectile dysfunction. Like, seriously? Teenage boys having erectile dysfunction? Like, that's a head scratcher. I don't know about you guys, but I know when I'm a teenager, and that wasn't a problem, all right? And so it's teenage erectile dysfunction has to do with addiction, porn addiction. And so there is a new field of study for these teenage boys that can no longer get erections because they're addicted to porn. And so they can no longer become excited unless they have some pornography in front of them. And I see some of those folks in therapy in their 20s. They're so addicted to porn, they can no longer have sexual intimate relations with their spouse or significant other because of that addiction. So it's a big one. Eating disorders, anorexia, bulimia, the ever so popular borderline personality disorder, dependent personality disorder. So it's useful for, psychotherapy is useful for those folks. Schizophrenia, that's one of my favorite slides, by the way, that picture. Or other disorders are called detachment from reality, psychotic disorders, schizoaffective disorder. Other usefulness of psychotherapy is coping with major life changes, divorce, death of loved one, loss of job. Now, all of you, again, are going to see this in your practice. Or, I don't think a day goes by that we don't have someone in our clinic. I work at UPA over there at Avera. Someone in our clinic, whether it's a secretarial staff up front, someone in the billing coding office, someone, one maintenance person that has some type of issue that requires psychotherapy. We just had someone, I don't want to break confidentiality, but they lost a sibling yesterday. So it's quite useful and it's quite common. Learning to manage unhealthy reactions, road rage. I've had some physicians that I've seen for outpatient therapy that were put on corrective action by their employer because of not road rage, but because of passive aggressiveness behavior in their clinic, not getting their billings and their progress notes in on time, and arguing with staff. And so then I see them for outpatient therapy. Physical health problems, diabetes, cancer. There's a lot of research that supports it. There's a correlation between major depression or anxiety disorders and some debilitating physical health problems such as diabetes or cancer. In fact, I do assessments for the renal transplant team for liver transplants and kidney donor evaluations. And those folks often have some type of mood disorders. Recovery from physical or sexual abuse or witnessing violence, so you have those PTSD symptoms. Other usefulness for psychotherapy, conflict resolution, anxiety, stress, coping with sexual problems, sleep problems, gender identity issues, employment problems, family problems. So you can see there's a wide variety of utility for psychotherapy. What format do we have those in? Well, we can see the folks individually. That's the one I think people think of the most, is seeing someone one-on-one. Group therapy, some folks may think, oh, what good does group do? Why why would you sit together with a group and what do you join hands and sing Kumbaya all day? Like, what good would group therapy do? There's really good research that supports group therapy is a better format for some problems than others. For example, I was referred by a psychiatrist to see this individual inpatient on the behavioral health unit because he was having fights and arguments with his wife. And I said, what kind of fights? And she said, well, the police have been called to the home once or twice, and he threw a lamp at his wife. And I said, no, I'm not seeing him individually. Why? Because research supports individual therapy doesn't work very well with domestic violence folks. In fact, let me tell you, you all are going to be mandatory reporters of abuse or trauma. If you're going to report someone or you're going to refer someone for domestic violence, you never, ever, ever, never, ever, never refer a perpetrator of domestic violence to individual or couples counseling. You don't refer them to couples, especially you don't refer them to marital counseling. Why? Because it puts the victim at risk of being abused again. And research clearly supports couples counseling doesn't work for those guys. Right? So you send them to group, and that's where I'm going with this. It's group therapy has been shown to be very effective for them. How come? Because they're sitting in a group of other folks that are confronting them about their BS. Okay? And then they don't have their spouse to be able to basically mind beat them up like they would in a marital couples counseling session. So if you get anything out of this, please remember that. Don't ever refer an abuser to marital counseling. It's dangerous. And we've got our marital couples format, and then family counseling. I cut my teeth doing family therapy and child and adolescent work. It's tough work, but couples work is worse. I would take a family and a 5-year-old, screaming 5-year-old over a marital session any day. So what type of approaches? Remember I said there's over 600 different approaches. The first one, we call him the father of psychiatry, father of psychotherapy, was obviously Freud. You probably studied that in your psychology 101 classes. That's the root of where many of our approaches today came from and stem from. And some of the concepts associated with psychodynamic theory are still with us today, such as defense mechanisms, such as denial, or transference and countertransference. That's still alive today. I'm going through these fairly quickly because I know we're limited on time. So with a psychodynamic approach, you probably won't see a whole lot of clinicians, at least here in the Midwest, use a psychodynamic or Freudian approach. One is because it's very labor intensive. Insurance companies, managed care likely won't pay for it. And you see someone sometimes up to 2 to 3 times a week for a period of 3 or 4 years. That's not very managed care friendly. And I'll talk about a couple approaches, and you all will be dealing with managed care, trust me. I don't care what fields you get into, you're going to be battling with insurance companies over things, and the same holds true for psychotherapy. So it's not a very managed care friendly approach. But there's components of it that are quite helpful. These are some of the terms that I was referring to that are still alive with us today. And I believe that there actually is some utility. I probably say 10% of the time I might delve into some psychodynamic kinds of concepts in my therapies. Behavioral theory, remember Ivan Pavlov, Pavlov's dog, B.F. Skinner, some of those strange, weird, the Hawthorne effect, all that stuff. Those were behavioralists. And so those are like in the 40s and 50s. And those folks their basic theory was just on a person's behavior. They weren't asking, they don't ask the client questions about, well, how's your relationship with your mother? They don't care. Like the behavioralists strictly want to know, to say, this is what you should do, this is how you should change things. So behavioral psychotherapies tend to be more directive, specific, and symptom focused. Again, what the heck does that have to do with you and your practice? Well, if you're referring somebody for domestic violence, or maybe you're going to have somebody with a conduct disorder, a teenager, or oppositional defiant disorder, research supports behavioral theories tend to work better for those folks. They tend to be more externally controlled. They're controlled by their environment or some consequence outside of them. They're not really internally controlled. The best example I had of is I saw a young man and asked him why he shouldn't steal out of people's cars, because he was, I said, what was going to make him not steal out of people's cars again? It's a conduct disorder. And he said, well, I don't want to get caught. I don't want the police to come after me. Last time I had to be in JDC for, the weekend. I don't want that to happen again. That's external control. He's controlled externally. Internal control would be someone say, that's wrong. That's the wrong thing to do. That's not my stuff. I don't go into somebody's car. That's inappropriate. That's internal controls. So behavioralists tend to focus on consequences and things outside of someone that will make them change that behavior. That tends to work better for criminals, antisocial personality disorders, like I said, domestic abusers. They tend to be more externally controlled, so you use a behavioral approach to change some of those behaviors that they might have. Also associated with treatment of specific phobias, anxiety disorders. One of my specialty areas is obsessive compulsive disorder, and we call it exposure response prevention. That's more of a behavioral type treatment strategy. It's the goal of most forms of behavior therapy is to increase desired behaviors and decrease undesired ones. It also works in some respects for alcoholic and drug abusers and gamblers as behavioral therapy. This just talks about systematic desensitization. We use that for social anxiety disorders such as fear of flying. Teaches problem-solving skills. What else? It might be more likely effective in patients with less initial severity of major depressive disorders. Let's keep going. Gestalt. You probably haven't heard of Gestalt a lot, but it's one of my favorites. Gestalt developed by Fritz Perls, and he spoke of, maybe you've heard this phrase, is the whole is greater than the sum of its parts. That came from Fritz Perls. What he's referring to is wholing is healing, and us becoming a whole person. There's lots of parts of us, but sometimes people will focus on one small part. So some of you may be focusing on, well, I got this medical degree. I'm going to be a surgeon. That's part of who you are, but there's more to you than that. You're a sister, you're a brother, you're a friend, you're a frenemy, maybe you're a boyfriend, girlfriend, spouse, wife, husband, brother, sister, co-worker. There's lots of parts of who make you up, but you put all those parts of you together and it still doesn't equal who you are as a whole person. So that's what Gestalt refers to, and they tend to be more here and now focused. I'm going to go through these fairly quickly, just so you have a general idea of some of the continuum and the wide variety of different theories that there are. Of the ones I've gone over so far, the one you're probably going to be most familiar with or hear out in the community is behavioral theory. You won't hear a lot of Gestaltists. Therapists believe that when one identifies, especially what is going on inside of them, change is initiated even though it is often an indirect process. DBT, boy, this is the one that's really getting a lot of press right now. Marsha Linehan, actually, she was here in Sioux Falls speaking about a year ago, and now they're trying to develop some DBT programming and units here at Avera. Not here at Avera, I think I'm in Sanford territory right now, but across town over at Avera. It was developed to treat people with suicidal thoughts and actions, used now to treat borderline personality disorder. There's some varying research about the effectiveness of it for other populations, but primarily know that it's best developed for borderline personality disorders. Suicidal folks that are cutters hurting themselves. I'm not going to read all of this, just the dialectical refers to an exercise, a logical blending or balance between two extremes. So borderline, how many of you are familiar with borderline personality disorder? Okay, a little bit, all right. If you're dating, don't date somebody that's borderline. That probably wouldn't be a good idea. If you do, make sure they're in treatment. They're very difficult folks to work with. But there's a continuum for those folks too. From a 1 to 10, you have the 10 scale borderline to a 1. So there's a continuum there. But they tend to think in all good, all bad extremes. They tend to think that way. There's not a whole lot of middle ground. And so that's what the dialect refers to, is helping them better understand that middle ground of seeing things. It emphasizes the value of strong, equal relationship. Research suggests DBT is effective for borderline personality disorder, reduces suicide attempts. I'm just going to stop right there. Humanistic. This is probably one of the more common ones that you've heard of or at least familiar with it through the media or through TV shows that are making fun of therapists, saying, oh, how do you feel? How is that for you? That kind of stuff. That's more of a humanistic kind of approach. You remember Maslow's hierarchy of needs, with self-actualization being at the top of the pyramid, and the bottom of the pyramid was just those basic needs, food, clothing, shelter that people need. But really the father of person-centered therapy would be Carl Rogers, or sometimes it's referred to as person-centered or Rogerian theory. And I think many aspects of theories today have some aspects of Rogerian or person-centered in them. I'm going to explain this here in a little bit. It refers to active listening, empathic understanding of what the client is going through. It's referred to as a third force psychology. It's referred to as helping a person feel as if they're understood and heard and valued. In fact, Carl Rogers felt that the primary variable of treatment is the relationship between the client and the clinician. It wasn't so much interventions or tools, it was how well that clinician can develop that relationship with the client, what I referred to a little earlier. Interpersonal therapy, and it's similar to Rogerian therapy, recognizes related affects, role disputes, social skills from acquisition of social supports. Rational emotive, boy, I just lectured on this on Tuesday to my 740 class, developed by Albert Ellis. Rational emotive therapy confronts a person's irrational belief system. So they're thinking in an irrational way and try to come up with a way to reframe or restructure the irrational thoughts that the person might have. There is a difference between rational emotive behavioral therapy and cognitive behavioral therapy. Not that you all are going to be tested on it, just so that you, if you hear that out in the field, that you know, okay, they do have some subtle differences. Generally speaking, if I say, what's the one big difference? I'd say CBT doesn't focus so much on irrational. It's more, think of more dysfunctional. It has more of a, it's more malleable. And probably the second biggest one is there's more research to support CBT, cognitive behavioral therapy, being effective than REBT. Aaron Beck is known for developing cognitive behavioral therapy. It's a blending of cognitive theory and behavioral theory, which I referred to earlier, and they kind of molded them together into CBT. And its focus is more on cognitive distortions. And those distortions are said to create and maintain negative feelings such as anxiety, depression. So one common distortion, I don't think I have any of these in, nope, I didn't list them. One common distortion is called polarized or black and white thinking, where people say, it'll never get any better. It'll always be like this. Nobody loves me. I'll never get a job. I'll be working in Sturgis the rest of my life. No one will, not that Sturgis is bad. I just heard Sturgis earlier. It'll never get any better. It's always like this. Nobody will ever love me. I'll never find a spouse. That's all or nothing thinking, and that's a distorted thought. Try to get the person to find that continuum, that gray area in between there. Another common one is judging. That's the should have, would have, could have thinking. Oh, I should have studied algebra more. I should have studied my trigonometry. Then I could have been a civil engineer. So that would have, could have, should have, generally referring to the past, that's called judging. So there's like 12 or 13 different type of cognitive distortions, and that's what CBT focuses on, is a person recognize, if I could put it in a visual picture, is how our thoughts connect to certain emotions, and those emotions connect to certain behaviors. So if I think, I'll never find a spouse, it's always be like this, I should have, worked out more. Well, then how's that going to make me feel? I'm going to feel frustrated, annoyed, upset, uncertain, worried, depressed, angry, upset. So if I feel that way, then how am I going to act or behave? I might not sleep well. I might eat 15 bags of Doritos and gummy bears. I might snap at my dog or my spouse. Then I start thinking, God, why the heck did I act like that? I shouldn't have done that. And it kind of is a more circular kind of process. So that's what CBT is really all about, if I can put it in a nutshell. I included Virginia Satir. She used a humanistic approach, and she spoke of these different survivor stances. So she referred to these survivor stances as ways in which we grew up to learn how to deal with our parents. or other adults in our or people in our family. And the best survivor stance is the congruent one, but the placator is the people pleaser. So you learn at an early age that if I try to please my parents, then I can avoid conflict with them. The other one is a blamer, that they're confronting. Maybe you had a brother or sister like this in your family. They always blame you for the problems. Or they blame some other person in the family for their problems. Or the super reasonable person. That would be the anal retentive person that has to know all the rules and logic. And they have to be very precise about things. And then the irrelevant person. I'm the oldest of 8. I had a brother, Sean. That was him. He was the irrelevant one. We'd be talking about something serious, and he'd ask about, are we having rice for breakfast? I mean, you just throw out something that's just really strange. Has nothing to do with what we're talking about. And that was a way to survive in the family, to just be irrelevant. And so she talked about these different survival stances that people might have. I'm not going to go through every one of these satir growth model assumptions. Just want you to be familiar with it if you hear that out in the field. Let's keep moving here because I know we're going to get close on time here. Boy, this guy's probably one of my favorite ones, Carl Whitaker, symbolic experiential therapy. It was also known as the therapy of the absurd. I'd probably say 30%. I do a lot of CBT. I'd probably say 30, 40% CBT. I'd probably say 20 to 30% symbolic experiential. It's referred to, that's got a misspelled word there. It should be referred, not refereed. Referred to as a therapy of the absurd. It's used to perturb or shake up the system. Caring takes the form of speaking the truth. Others are unwilling to speak. That's what he was known for. And so what is symbolic experiential referred to? Is using the symbols that a client says as a metaphor to get my point across. So for example, I had a young lady last week that I saw outpatient. Actually 3 or 4 years ago, we found she was bipolar disorder. She was put on, I don't know if it's Zyprexa or Risperdal, I think it was. But anyway, she gained a significant amount of weight. Some of you probably already familiar with that. And so I've been trying to get her to exercise and watch her diet, take better care of herself. I'm going to try and make this short. Her husband isn't very nice to her, calls her some really horribly mean names, but she won't do anything to take care of herself. And she was in a depressive state. She wasn't in the manic, hypomanic state. She's in a depressive state. And so I haven't got anywhere with her to get her to start taking better care of herself. So one of the things, I was using this as an example so you understand what symbolic experiential refers to. She says, well, Dr. Jackmon, I'm just in a rut right now. And so rut, I'm going to use the metaphor of rut to try to change some of her thinking. I said, oh, so you're in a rut. I said, it sounds like it's in a really, really deep rut. And she says, yeah, it's pretty deep. I'm like, so if you're in a deep rut, I'm like, how do you get out of that rut? Does somebody just sprinkle some pixie dust over the rut? You just levitate right out of the rut and everything's fine and there's unicorns and glitter? You know, how do you get out of that rut? Like if somebody puts a ladder down in that rut, how are you going to get out of it? Well, I have to climb. Oh, so you mean you're going to have to use some energy. It's going to take some energy for you to climb out of that rut. I said, maybe you like to stay in that rut because if you stay in the rut, you don't have to see what's going on outside of here. You could just stay nice and cozy down there and ignore everything that's outside of the rut, which is basically what she's been doing. She's been skipping work. She doesn't confront her husband about getting the dishes or working around the house. She just ignores everything. And so I'm using that as an example to explain what that symbol. You can use those phrases, those metaphors that people use as a way to make them think about things a little bit differently. And that connects somewhat well with CBT, because part of CBT is to change a person's thoughts. So if I can change her to thinking, well, wait a minute, I'm in this rut. How do I get out of this rut? If somebody puts a ladder down there, that means they're giving me some help, but it's going to take some energy for me to climb out of that rut. And then I have to decide what I'm going to do once I get out of it. So it makes them change how they're thinking about things. I'll give you another symbolic experiential one. It was somebody's talking about swimming. You all can borrow this one too if you want. When I was doing family therapy, this kid that was I see an outpatient, and I see them do the family work, and he said, "Well, when I beat up my little sister, that shouldn't affect my mom and dad. They're outside. She doesn't care that I wrestle around with her, and my mom doesn't. It's not that big of a deal. Why would it affect everybody else? They're not even around when I yell at her or call her names." But he loved to swim. And so I used the symbol of him swimming. I said, so if you're in a swimming pool and somebody takes a dump in the swimming pool, okay, don't you think that affects everybody in the swimming pool? All right. So I said, a family is like a swimming pool. If somebody do I have to explain what a dump is? Okay. If somebody takes a dump in a swimming pool, it affects everybody. So you can't just say, because you're doing this over here in this part of the house, it doesn't affect everybody. Nobody wants to be in that swimming pool if you're on the other side and there's floaters over there. They don't want to be there. Like, you have to stop doing that if you expect everybody else to want to stay in that same house, or they're going to kick you out of the house, so you stop dumping in the house. So you can use those symbols that people say as a means to make them change how they're thinking about things. All right? You guys are going to remember that one. All right, therapeutic relationship. I'm going to keep moving. Use of self. Helping them accept responsibility. So if I use that swimming pool analogy, he had to accept responsibility. No, dude, you're the one doing that in that swimming pool in your family. You're doing that. Here and now experiencing. It's playful. It's crazy. Yeah, it's spontaneous. But obviously, I wouldn't do that in my first session. It would be something where after I've developed a relationship with that client. They know me. Okay. Absurd fantasy alternatives. Let's keep moving here. Treatment approaches. I talked about cognitive behavioral. Or maybe I did talk about this some. Is getting them to change how they think about things, become more optimistic, more realistic self-talk. Talk about this attribution bias. We talk about cognitive behavioral. Thoughts, emotions, behaviors. Hops and others spoke of this attribution bias, meaning that a person with that mindset readily assumes personal blame for negative events. So if they're pessimistic, they think everything's their fault. It's almost like they're looking through a lens, looking for anything that might suggest that something is their problem or their fault. Thoughts affect how we feel, and that affects how we might behave. I gave some examples of this a little bit earlier. So in a job situation, the person might be telling themselves that I'm not good enough, I'm to be treated well, my feelings aren't important. And so obviously those thoughts can lead to them having a lower self-esteem or having some depression. And so we want to help them change their self-talk to something that's more positive, something that's more realistic. And then if I can change those thoughts, such as I'll never amount to anything, if I can change that thought to, well, you've been successful in getting through high school, you're successful in coming here for this therapy session, that's something you've been successful in getting a few things done, then that might change how they feel about something and make them feel more positively and act differently. How do we do that, or how do clinicians do that with CBT? They identify the negative self-talk, they challenge those thoughts, and they might use anxiety management, such as muscle relaxation, diaphragmatic breathing. In fact, there's been some research that supports that folks that are having panic attacks, that using that 4x4 diaphragmatic breathing, it's almost impossible for them to continue to have those panic attack symptoms. Thought stopping, but they have to recognize the negative thought first. So CBT is going to be more educational too. Role modeling, role playing. Now, some of you may think, role playing, didn't that die out in kindergarten or Romper Room or Sesame Street? To be honest, sometimes role playing with my clients has been extremely effective. So they may come in and say something like, well, every time I try to talk to my husband about doing more dishes, I'm on this dishes thing because I just had a client last night who was talking about her husband didn't do his share of the chores. And in the United States, statistically speaking, women do approximately 80% of the household chores in the United States. 80%. Okay, so that means men, we need to buckle up. We need to get our stuff together. And so So role playing, role modeling. One day I said, "Oh well, I'm going to be your husband. You be him. You be yourself. Tell me how you talk to him." Or I flip skill. Okay, I'm going to be your husband, and I'll say something to her like, "Well, I don't need to do those dishes. That's a woman's job to do the dishes." Now, how are you going to respond to that? And then we'll flip roles. So it's a way. It's a modeling way. It's a way to teach them how to be more assertive. So role playing, role modeling, it can be effective. I wouldn't poo-poo those ideas. Multisystemic therapy. I included this one. We had about 5-10 minutes here. Because social workers, I got my master's in social work. Like I said, I teach in a social work program. The systems theory is something we prescribe to quite extensively, referring to how different systems interact on an individual. So for example, you all are medical students, correct? Okay, so think of all the systems coming into play. You have the medical school, USD, that's a system. You have your family, that's a system. You have Avera, and you have Sanford. You might have your professors that you visit with. Maybe you're eventually going to do a residency. All of those systems play a role in affecting you as an individual. And so systems theory refers to, as a social worker.
I don't know if it's right, but no, we're still here.
Jeez, we just totally interrupted.
We're hearing voices. That's psychotic thinking there. With a system, as a social worker, I would want to know how to navigate between all those systems. What are the boundaries? Who do I talk to in human resources at Sanford to help this individual that I'm working with? So all of those systems play a role in affecting the individual. It works well with problem behavior such as conduct disorder, substance abuse, severe depression, suicidality, delinquency. Like, well, how does systems theory work with a conduct disorder? Conduct disorders, I always refer to the difference between conduct disorder and oppositional defiant disorder. Oppositional defiant disorder are those kids that are like Dennis the Menace. They're annoying, and they don't want to follow rules and don't want to listen to authority figures, and they're arguing, and they're angry, and they blame people for problems. Conduct disorders are Son of Sam. They're Charlie Manson, okay? They will they'll smile in your face and break into your car and slit your throat. They're dangerous, okay? They're truant from school. They're sexually assaulting people. They're stealing things. They're using weapons and knives to harm people. So they're dangerous. Like, well, why would multisystemic work good for those folks? First, they're externally controlled. So what's outside of them? Those systems, such as their school, their grandparents, a probation officer. Okay, they're on probation. That's why we see a lot of them on probation, because you need those external systems to help control that behavior. So systems theory works fairly well with delinquent individuals. All right, good. Got 7 minutes for questions. Any questions about? Let's try to go through that as quickly as possible so we can get to Dr. Ermer coming up here pretty quick. Any questions about psychotherapy?
We don't use the ink blots anymore?
That's a good question. The ink blots, the Rorschach ink blots. That's a approach that we'd use for like psychodynamic kind of theories. Yes, there are clinicians that use those. There's not a whole lot of research that supports the validity or the reliability, because it has to do with how I would interpret those ink blots. So how you might, as a clinician, think that person is saying something about those ink blots might be different than how I see it. That's an excellent question, because that's a one tool in our tool bag that we might use to assess an individual. So ink blots would be one, the Rorschach, but the reliability and validity isn't very strong. Whereas with some other instruments, like maybe your Beck's Depression Inventory or your Beck's Anxiety, the GAD-7, those have pretty good reliability and validity, because when a client fills those out, no matter who scores those, all of you score them, whatever that score is, we're all going to say, oh, yep, a 37, that's high depression, right? But even with an instrument like that, I'm glad you brought this question up. With an instrument, even with that has issues of validity. It's called face validity problems. You all should know this one. For Beck's Anxiety Inventory, for example, it's a measure of, what does it measure? Anxiety, thank you. All right. It's the anxiety inventory. The problem with some of those types of inventories is they have face validity problems. This is really important for you all because some of you are going to be confronted with this. Is we have family practice clinicians here in town. We have psychiatrists here in town, right? That'll use a Beck's, not you, but use a Beck's anxiety inventory to determine, oh, they got high anxiety. We should give them a benzodiazepine. All right, when we know benzos are highly addictive, all right? Well, the problem with using that instrument, because it has face validity, if I wanted to get a benzo, all I have to do is do 4s all the way down there, and I'm gonna have a high score. So be careful when you have some of those types of inventories that the client can tell what they need to do to check off to get a high score. Another common one is the Conners, the CARS adult rating scale. That's one that we use to rate for ADHD. Well, if somebody wants to come in for ADHD to get some stimulants from you, for you to prescribe, all they have to do is do all 4s or the high, and they'll get the high score, and then some providers will go ahead and make that prescription. So be careful if you see clinicians or folks in your office using instruments that have face validity problems. Does that make sense to people? Okay. You say, well, how do I get around that? Well, there are very good instruments that a client can fill it out and they can't tell what they're filling out for certain. That's why you see a lot of psychologists use like the MMPI because a client can fill it out and they don't know if it's going to make them ADHD or depressed. They don't know. They can't tell by those questions. Like, for example, one of the questions on MMPI is, first one is I like mechanics magazines. Well, you can't tell answering true or false. Is that going to make me ADHD or not? There's like 567 questions. I won't go into great detail about it, but the ink blot question is a good one. There are some clinicians that use that, but the utility problem is validity and reliability from a research evidence-based perspective. Any other questions? Yes.
How do you, so just because I've been coming to this at the VA, patients that would benefit from therapy but don't want to do therapy because it's got negative connotation. What if my friends find out that I'm seeing a therapist, you know, especially like some of the, you know, the vets, the Army, you know, they're like, I can't go to therapy because I don't want my, you know, how do you overcome those?
That resistance to just the stigma associated with coming to therapy, that is a tough one, especially for a generation that may have fought like in Korea or a Vietnam War veteran. Sometimes I'll use stories of, you know, I had a couple individuals like that, you know, 2 months ago, and you know they thought the same thing about us psychotherapists, head shrinkers. You know, we don't know what the heck's going on, but you know, man, he got through his depression within 3 to 4 sessions. So I'll use a story to kind of maybe help decrease some of that resistance they might have. I might use statistics and say, well, you know, that's pretty common. You know, folks that are aged somewhere between 40 to 60, you know, they have kind of a negative, a good majority of those folks have problems with psychotherapy. They don't see that that's going to be very effective or having a stigma attached. So that's pretty normal. So normalize or universalize that experiment with them or that experience with them. Or I might say if they're coming to me as a clinician, like, well, you know, I got referred by my family practice and I got to come to therapy and think it's really dumb. I'm like, well, how about we use this as an experiment. Let's do this for 2 sessions, and by the second session, if you don't see this as value, you can just come back and tell me, Dr. Jackmon, this was the dumbest thing ever. And I'll say, now challenge them. You know, give me 2 sessions. Let's make this as an experiment, and we'll see how it goes after 2 sessions. Usually, they might be willing to give something 1 or 2 times, and then I got to make sure I find something that they are having some degree of success by the time they come to that second or third session. So yeah, it's hard to get some of those folks in if they already come in with a negative, or here's another one, they've been to therapy before with 2 or 3 providers and they didn't get any help. It didn't help them at all. In fact, then sometimes they'll say, it was even worse, it was stupid, it was dumb, I didn't get anything from it. Those folks are really hard to get them in for another chance. It's all about me developing a relationship with them. It's a good question. Any other questions? All right, welcome.